Welcome everyone to the Dia Soren booth at ADLM for this podcast titled The Sepsis Puzzle, Why It Takes More Than One Piece. I am your host, David Engman, former chairman of pathology at Cedars-Sinai Medical Center in Los Angeles. And today we are joined by Sean Carey and Chris Soto from Deborah Heart and Lung Center, which is exploring a multi-biomarker approach to assist in the evaluation of patients with possible acute infection. There are several aspects of their approach at Deborah that are unique. I know you'll enjoy hearing about their approach. The subject of the podcast is the MIMED BV test. This test distinguishes bacterial from viral infection not by directly identifying the pathogen, but indirectly by measuring the host immune response to infection, which differs in a general and reproducible way depending on whether the infection is viral or bacterial. This test has a very high negative predictive value of nearly 100% and a good positive predictive value of 70% for bacterial infection. That is, it was developed to rule out bacterial infection and allow withholding of antibiotics in most cases. So both of you, could you please introduce yourselves and describe your various roles at the Deborah Heart and Lung Center?
Sure. Thank you, Doctor. Sean Carey, and I'm the manager of the lab, overseeing several areas, well, actually the entire lab, and specifically micromolecular immunology.
Hey, Doctor, thank you for having us. I'm Chris Soto. I'm the lab administrative director for Deborah Heart and Lung, where I oversee the whole lab, the quality and testing and all that, fun stuff that my job entails.
Very good. So, Sean, when and why did you decide to evaluate the MIMED BV test at Deborah, and in what patient populations?
So we decided to use MIMED for hard cases that we didn't know was potentially a viral or a bacterial infection. Specifically, pneumonia patients is where it seems to thrive a lot.
And Chris, your study focused on expanding your complementary biomarker strategy. What did complementary mean back then when you were talking about multiple biomarkers?
So complementary means most of the biomarkers that we were using, so we used CBC, lactate, procalcitonin, those normal, biomarkers, but we needed something to identify an infection faster to get our patients in and out the door without multiple, unknown things and guessing, so the doctors could, if it was an infection, an active bacterial infection, doctors could treat it faster.
So with that panel of markers, how was it typically interpreted, the results of the multiple biomarkers? Were there certain individual tests that were more meaningful or given more import into the decision, or was it, how did that actually work clinically?
So originally when I first got to Deborah, there was a big blood culture bottle shortage, and me and Sean worked on this, I guess, how to tackle that blood culture shortage. So we sent out better information on how to read these biomarkers. However, you can only educate providers so much that they're coming to you every day with these questions on, hey, how do I interpret this? How do I interpret that? So we needed this extra kick to get us over that hump to then give them that security in their own, diagnosis, their own role to be able to diagnose the patient with a viral or bacterial infection.
So that seems like a real partnership then between the clinician and the lab that
Yes.
led to the development of this. Yeah.
Yes.
So moving on to the study then. Sean, can you describe exactly what your approach was and what your basic goal was in adding MIMED BV to that panel of tests and what you were looking for?
Sure. So we wanted a higher specificity and sensitivity for a sepsis bundle or complementary set, now called the infection detection set. And we put MIMED in there because of its high specificity and sensitivity It pairs well with procalcitonin, and it appears to lead in terms of the other biomarkers. So it shows up right away in comparison to, say, lactate and procalcitonin, which take a little bit longer for them to kind of start moving.
And so what were the key findings from your study, and how did you set it up then? Over what period of time, and how many patients, and so on?
So we did almost 120 patients, and we specialize as a geriatric hospital. So most of our patient population was over 60 years old with comorbidities, and we just started sending out this complementary biomarker set for both the provider and lab to have this type of partnership, like Chris was saying before. And we can quickly detect an infection with about 92% predictive power.
Did you compare the results of that sensitivity and specificity with and without the MIMED test? Did the MIMED contribute to that high sensitivity?
Yes, greatly. It helped out a lot, and it helped determine the etiological type that we were dealing with.
So either one of you, do you think that the clinicians, these are inpatient physicians, are equally or more concerned about whether the infection is bacterial or viral versus knowing the actual identity of the pathogen?
I think they are more, concerned based off of the new, the infection control guidelines, right? We want to catch these bacterial infections and start giving the appropriate antibiotic as soon as possible. We've also done a lot of other stuff to assist the providers to know what type of bacteria it is in our lab specifically. So I think when you're treating these patients that have these comorbidities as severe as what we've encountered in our hospital, it is more important for them to know if it's viral or bacterial versus actually knowing what the actual bacteria is.
So these clinicians were given, so the MIMED was clinically live and reported in the EMR or to the physician through a phone call even. The tests in your panel have different turnaround times. So did you find, or did you ever study whether they were ready to act clinically on some test results that came earlier, or did they really wait for the entire set to come back before they made a clinical decision, do you think?
I think initially when we implemented the test, they were just running with the initial order set that we had in place because, MIMED was a brand new test. They needed to see a few of the results to be able to have that confidence in the test, like every other, lab test that's implemented. But once it was in place and they were able to see that test can really guide their diagnosis, I think they were waiting for that to then correlate all of the markers to it. And still, once we implemented, they were still coming down to ask Sean and I's expertise on how to interpret all of the biomarkers together, and that really helped our length of stay and antibiotic stewardship program in the hospital.
So did it help both in a positive way, meaning the results led to antibiotic prescription, and or a negative way, which meant the results might lead to withholding of antibiotics when they weren't felt necessary?
Both. So in the positive way, it shortened length of stay, right? A patient could come in and they're not with that question mark of, oh, is it viral or bacterial? Let's start giving them antibiotic. With it being a viral infection right now, we have a biomarker that can tell us if it's viral or bacterial, and I don't have to give the antibiotic. So the antibiotic usage went down, but it also went up, right? So we were able to So it sort of like leveled out. We were able to give it to when people needed it, and when people didn't need it, we withheld it. But it also shortened that length of stay. There's a case the other day that me and Sean were working that we actually caught a patient with a CODI in our hospital, and you know that CODIs and stuff like that affect reimbursement for the hospital. So they were sort of mad that the MIMED caught an active infection before the person was about to be discharged. So I mean, it works.
So all the other markers were not pointing to an infection, and the MIMED score
Yes.
came back and did that.
Yes.
So I know this study happened over a period of time, but do you feel your clinicians are now using the MIMED test more comfortably than they did at the beginning, or do they still, are they using it as part of a multi-marker bundle now?
They are. They actually requested that we add it into the bundle and make it like a set bundle. So they just go in and order the sepsis bundle, and that test automatically orders. So they're more confident now than when we first started using it. So it took us a little bit because our IT program is a little slower in managing the order sets for the providers. But once it got added, the providers are,
So, Sean, we talked about this one recent case, where the test revealed a potential bacterial infection. What about others? Are there other examples of cases where the addition and inclusion of the MIMED test in the panel was particularly useful?
Yeah, we're getting a trend with procalcitonin, which we see will elevate a little bit afterwards when MIMED elevates pretty quickly. We're seeing that trend a lot. There's also that one case where we didn't know what this one patient was, and they sent a respiratory panel. They tried other culturing efforts. They came back with tuberculosis, latent tuberculosis, and we always confirm it. However, when the second draw was being done, we decided to do a MIMED, and they got a 100 bacterial score, confirming the suspicions as well.
And then you said, you mentioned at one time that the follow-up testing, when that second draw came back, what was the result of that?
So that was positive as well, specifically for TB2.
All right. Now, what about when the conventional markers are contradictory? You mentioned that the biomarker dynamics are different depending on whether you're talking about a white count or your neutrophil lymphocyte ratio or procalcitonin lactate I mentioned. How does the timing or the temporal expression of those biomarkers during bacterial infection affect how you interpret your panel and maybe resolve some contradictions or inconsistencies within all the panel results?
So we see that lactate and procalcitonin are slightly lagging. The CBC seems to be pretty on point, though there are some dynamics within. The MIMED is very quick to jump critical if needed, if it's a bacterial infection, and that algorithm, or the 92% predictive value, is based on two critical values. So MIMED and NLR, the neutrophil to lymphocyte ratio, are the two that seem to spearhead this complementary biomarker set at that time, at a specific time.
So Chris, looking back now, what has been the biggest impact of including MIMED BV in this multi-marker approach?
The biggest impact, as healthcare facilities around the country right now is financially, right? So we have reduced that length of stay, so now we can actually charge the patient and not overcharge a patient, right? And plus it'll help with length of stay and antibiotic stewardship, right? reducing that cost of antibiotic that we have to purchase, and then that the patient has to, or the insurance has to reimburse. So financially is like the biggest cost if we're looking at like my role, right? But if we're looking at the in regards to the patient, it's catching an infection as fast as we can get it to get them treated and back on the road or back to doing day-to-day things.
So you may not care about this much, but your administrators do care about patient satisfaction scores and all of that. So, I mean, I guess another question was, how do you see using a multi-marker approach evolving in both emergency and inpatient care in the future? I mean, here you have MIMED test and its role in assessment of potential infection, but do you see common applications of other multi-marker tests to other disease entities going forward?
Yes, I think this is the tip of the iceberg in terms of lab standardized diagnostics, where we are cooperatively working with bedside, and both the lab and providers are doing what's best for the patient. Like Chris was saying, quickening the length of stay, preventing comorbidities, and reducing mortality rate. But we see that this standardized diagnostic, whether it be all at once, stratified, will be the future for quickly diagnosing patients with certain diagnoses.
Now, you are a unique clinical institution with a focus on heart and lung and a lot of pneumonia patients, but what advice would you give to others who are considering implementing or evaluating MIMED BV for their own evaluation of potential acute infection?
I would say implement it in their ER. The ER, that's where we get the majority of the incoming infections or patients presenting with potential infection. If you implement it in the ER, then you don't have to do it with a patient already in-house, right? We're doing it more with patients that are already in-house that are have undergone the knife already, and we're trying to not get a hospital-acquired infection, or they've come in with an infection and they've gone under the knife, and now they have this complication. So we're trying to, if you implement it in the ER, we catch it immediately and send that patient back home, and they're a lot happier than having to come back later to the ER, even worse, and get a hospital stay where they have to get IV antibiotics versus oral.
So I assume that there are a handful of ERs that feed into Deborah. Have you discussed these results with them to maybe encourage them to implement testing or to at least evaluate it there before they come to you?
Yes. So after we did this study and we presented our poster, Sean went through all these ERs to hand them our study and talk more about the study. Unfortunately, I busy, but Sean's a very good advocate for our lab, and he was able to talk to these ERs about the study. I talked with some of the directors to see how they can implement it and how it's helped us. So we did all the give them all the stats, all the financials and everything, and the patient satisfaction scores, and that's how they're looking at potentially implementing it for them.
Right.
In the
I
future.
imagine your clinicians are also important in that communication as well.
Oh, extremely. Once one clinician is on board, they sort of act like a competition between themselves, and they're like, I ordered more MIMED, I was able to stop more infection than you type thing. They're all, I don't know if you know about cardiologists, but they're very competitive within themselves. So.
Yes. Any final thoughts from you, Sean?
Yeah, I mean, we're really enjoying this test. We like the complementary standardization, and also to add to what Chris was saying, financially and rapidly, we are helping the patient. I mean, this is only a few $100 test, the bundle, and compared to thousands of dollars that they would be staying or wasted with a case that may not be as true without this.
Okay. Thank you, Chris and Sean, for sharing your insights into the evaluation of this MIMED BV test. And for listeners at ADLM, be sure to visit the DiaSorin booth and website to learn more about MIMED BV and other testing. Thank you.
Thank you,
Thank
Doctor.
you, Doc.